Ladies and gentlemen, welcome to the Lake Superior Quality Innovation webinar on the importance of foot care and immunization for diabetic patients. Your host, Michelle Dewey, will now begin.
Thank you, and good afternoon and welcome. My name is Michelle Dewey, and I'm a clinical quality consultant here at MPRO. Today's webinar is presented by Lake Superior Quality Innovation Network. Lake Superior Quality Innovation Network is comprised of 3 organizations: MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Service priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior Quinn YouTube page within the next week. No commercial support has been received for this learning activity, and the speakers have reported no conflicts of interest, and there are no planner conflicts of interest. We have 2 presentations this afternoon. The first will focus on foot care in diabetic patients, and the second will be a brief presentation that highlights immunizations and the role it plays in treating patients who have diabetes. I would like to introduce you to today's speakers. First, we have Dr. Sari Priesand, who is a podiatry fellow with the University of Michigan, and our second presenter is Barb Link with MPRO. So at this time, I would like to turn it over to Dr. Sari, please.
Hi, everybody. So I am a podiatry fellow at the University of Michigan. My fellowship actually focuses on diabetic limb complications and the microvascular complications. So we'll get started. So essentially, this whole PowerPoint is focused on the comprehensive diabetic foot evaluation, and we'll go into a couple of different aspects of that. I have no disclosures to report. And there are 4 main objectives to my talk. The first one will be reviewing just the current ADI guidelines for the comprehensive foot exam and the risk assessment. From there, we'll go on to reviewing some of the diabetic microvascular complications and the important things to look out for, and specifically for foot care. And then based on those diabetic microvascular complications, we'll review the risk classification system and then follow-up recommendations for that, so to decide how frequently people should be followed up as outpatient. And then after that, finally, we'll just end with the review of the documentation guidelines for the diabetic verification form for the diabetic figure and insert. Just to start, we'll go over a couple of statistics. So as we know, in 2015, 30.3 million Americans, 9.4% of the population, had diabetes. 84.1 million Americans had prediabetes, adults. And then depending on the different categories, the annual incidence rates for diabetic foot ulcerations may vary from 5% to 6.3% of the global population. And 9.1 to 26.1 million people worldwide develop diabetic foot ulcers annually, with 1 to 3.5 million Americans having a history of diabetic foot ulceration. The lifetime incidence actually is 19 to 34%, so it is quite high, which makes all of this really, really important. In terms of hospitalizations, this is just from the National Diabetes Statistics Report from this year. And in 2014, there were actually 108,000 lower extremity amputations that were linked to hospitalizations for adults with diabetes. So, it's on there with the list with ischemic heart disease, stroke, and other diabetes-related complications as well. In terms of looking at it when compared with different cancers and the 5-year mortality percentage, I think it's something important to understand that even something as small as a diabetic foot ulcer or an ischemic ulcer actually has a 5-year mortality that is on par with other cancers, and in fact does surpass the 5-year mortality of some of the more well-known cancers such as breast cancer, prostate cancer, and things of that nature. And it's just something to keep in mind that it's not benign. These ulcers do have consequences, and the 5-year mortality is quite high, especially for these ischemic ulcers. The natural history of a diabetic foot ulcer, like I mentioned, with mortality, the risk of death at 5 years for a patient with a diabetic foot ulcer compared to a diabetic patient without a foot ulcer is 2.5 times higher. And more than half of these ulcers become infected, and the majority of them do require an admission to the hospital. About 20% of the moderate to severe diabetic foot infections do go on to needing some sort of amputation. And PAD, peripheral arterial disease, is obviously very important, and we'll go into that a little bit later as well. And the mortality after a diabetes-related amputation exceeds 70% at 5 years, and if the patient is on hemodialysis, it actually is 74% at 2 years. So can be quite high, especially if there's infection. So moving on to our objectives, we'll now review some of the more recent ADA guidelines for the comprehensive foot exam. There are 9 basic general recommendations for the foot exam and relating to the microvascular complications, and we'll go through all 9. But if you read this article on your own, it does go into more detail. But we'll just kind of briefly talk and touch on each aspect today. So the first one is that a comprehensive foot exam, at least annually, is performed to evaluate the risk factors. And we'll go into a little bit about when the risk factors play a different role and making it important that the patient is seen more frequently. But if at the very minimum, their feet should be evaluated every year. And then all patients with diabetes should have their feet inspected at every visit. So whether they're coming in for something else, it's just important to take a look and make sure there's nothing going on. But I also would add to have their shoes evaluated. So when you're taking a look at the feet itself, you want to make sure that there's nothing going on with the shoe gear. So if there's a needle sticking through the bottom or if there's a lot of wear and tear, it's just something to keep in mind that you can advise the patient on helping them with that. And then the third thing is evaluating the history. So when you're specifically focusing on the feet, asking a couple of these things is really important. So any history of prior ulceration, amputation, history of Charcot, which we will go into in a little bit more detail later on in the talk, any history of vascular surgeries, cigarette smoking, retinopathy, renal disease, any symptoms of neuropathy such as pain, burning, numbness, anything to that effect, and we'll go into that a little bit later as well. And then vascular symptoms. So if the patient is complaining of leg fatigue or claudication, it might be a good idea to initiate the screening process for that. Number 4 on their list was the physical exam. So we'll go into this also in a little bit more detail, but very generally, the exam should encompass the skin inspection, meaning in between the toes, the heels, everywhere, the foot deformity assessment, so evaluating for things like hammer toes, bunion deformities, flat foot, high arched foot, things of that nature, the neurological assessment, and we'll go into this a little bit more detail because there actually has been an additional update. But based in this evaluation by the ADA, the recommendation was to perform, whenever you're screening for neuropathy, to utilize the 10-gram monofilament, and we'll go into how to do that as well, with at least one other assessment of the following. So either pinprick, temperature, vibration with the tuning fork, or ankle reflexes. So you pick 2, one of them being the 10-gram monofilament. But we'll go into it in the next slide or later on why there's been an additional change. And then the vascular assessment. So palpating for the pedal pulses, the drossalis pedis, and the posterior tibial. And then if the pedal pulses are not palpable, then moving up to the popliteal and potentially the femoral to see if that's palpable. The 5th recommendation is in terms of the vascular assessment. So patients who are older than 50 who have not had any vascular workup, such as arterial brachial index or toe brachial index or PVRs, should really be worked up. So if they're older than 50, if they smoke, if they have any symptoms of claudication or peripheral arterial disease, any signs of physical exam of decreased sensation, lack of hair growth, cold feet, anything of that nature, they really should be referred for a vascular assessment. And that could be as simple as just having an ABI or TBI performed, and if it's abnormal, then referral for a formal vascular workup as outpatient. And then leading me to number 6, which is the multidisciplinary approach for these diabetic foot ulcers. It does take a big team to manage these high-risk feet. And you can see the list of the different specialists that are involved. Podiatric surgery, which is where I come in, and then endocrinology, vascular surgery, and the list goes on. And there's a lot of different aspects, and depending on the patient's risk factors, they may require all of these or maybe just 2 of them. But it's important that if they do need necessary referral, which moves on to recommendation number 7, that it gets implemented effectively. And then moving on to recommendation 8, providing, at every visit or at least at their comprehensive evaluation, recommending preventative foot self-care education. So if you're making recommendations for other things, you probably want to add in there some recommendations for good self-care diabetic foot recommendations, such as avoiding walking barefoot, checking your feet every day, good glucose control, contacting if there's anything important, such as any new foot issues, contacting sooner, anything of that nature. And there are guidelines that you can find on UpToDate and other sources that just are nice lists of just items that patients should be doing every day to make sure that they have good foot health. And then last but not least, recommendation number 9, which I will get into at the end specifically on footwear, the importance of diabetic shoe gear or just good therapeutic shoe gear with orthotics or inserts. And we'll go into that at the end, so I won't take too much time on that now. So this is what I was talking about earlier regarding the neuropathy statement that just came out by the ADA as well. So this article actually made some additional changes with the screening. So first and foremost, they recommended that all patients should be assessed for neuropathy, starting at diagnosis of type 2 diabetes, and then 5 years after diagnosis of type 1 diabetes, and then from there, annually at their comprehensive foot exam. Optimal glucose control is extremely important, as it does help prevent or delay the progression of neuropathy. However, good glucose control will not reverse neuronal loss. So important to realize that. But getting good habits early and having improved effective glycemic control early on can help prevent or delay the development. And then they're even recommending that people with prediabetes get screened as well. So just something to think about. And then this is where the big change comes in. So before I told you that they were recommending to use the 10 grams Simplancy monofilament plus one of the other 4 options. But now they're actually recommending using the tuning fork for vibration, using the 10-gram monofilament, and then choosing either temperature or pinprick. So the goal of doing all of those things is to evaluate the small and the large fiber because neuropathy can affect both. So what they want to do is evaluate for potential sensation by using the monofilament, and then evaluating the large fiber by using the tuning fork, which will evaluate the vibration sensation and any diminished sensation with that. And then evaluating the small fiber neuropathy by utilizing a temperature sensation or pinprick. And then last but not least, if there's any sort of question of concern, electrophysiological testing or referral to neurologist can be implemented, but it is rarely needed. And if the diagnosis is unclear or if you're not sure if it's diabetic neuropathy, then probably is a good idea because there can be various different ways where patients can present with numbness or pain or burning in their feet. So this is just one of them, but especially if they're getting screened, it's something to keep in mind. So that was just a review of the current EDA guidelines, and now we'll go into a little bit more on the microvascular complications. So the triad of different causes that actually cause these ulcerations is neuropathy, which we just reviewed, deformity, so hammer toes, flat foot, high arched feet, trauma. So really, it's a cyclical event. So the patient will start with uncontrolled diabetes, which causes the neuropathy, and then from there, they may have a traumatic event, or they have a deformity which predisposes them to a traumatic event, such as rubbing against the shoes. They develop an ulcer, and then because of their diabetes, they have impaired healing, and then so on and so forth. So we try to break the cycle in terms of trying to cut it somewhere, so that way things don't continue and fester. So here's a nice schematic of how the calluses can turn into a pre-ulcer callus and then can eventually turn into an ulcer. So essentially what happens is on the right here under Table 1, just lists out the various different risk factors that people develop these foot ulcers. A big portion of our patients do have peripheral vascular disease, but obviously a lot of these things can cause ulceration as well as re-ulceration. So the most common type of ulceration that we see is a re-ulceration. So the site of ulceration from before is actually really predisposed to developing an ulceration at that site as well. So essentially what happens is patients develop a callus or a blister that they keep walking on the area because they don't realize it's there and they don't feel it. What happens is you get subcutaneous hemorrhage. So when you see that callus or blister with blood underneath or it looks like it has blood tinged in there, that's concerning because what ends up happening is the ulcer is forming underneath and it's not visible to the outside. And then eventually, either with debridement in the office or skin breakdown over time, the ulcer forms. And these are relatively painless for most patients. So going into the different components of the foot exam, so when it's performed, obviously we talked about the different history items that we should be asking. We talked a little bit about general inspection, the musculoskeletal assessment, really looking at deformities, neurological assessment we talked about, and then the vascular assessment we'll get into a little bit more. So here are just additional details on essential features of the history, key components of the diabetic foot exam, and we talked a little bit about the additional testing that's needed for the neurological assessment. And making sure, I'll go back one sec, just making sure that when you check the feet, checking in between the toes is super important because interdigital ulcers can hide in there if you're just quickly glancing at the foot, as well as the heel on the back. So people can get fissuring of the heels, whether, this time of year, especially with the dry skin, and those fissures and cracks can open up and become full-blown ulcerations, and even pressure ulcers, I'm sure you all know, they can hide from us. So you really want to make sure you check the bottom of the feet, all aspects in between, and the back. So a little bit more detail about neuropathy. We talked about when people should be assessed and screened, but going a little bit more to the small and large fibers. So when people are screened for symptoms, they can present differently depending on what kind of neuropathy they have. So if they have pain associated with a neuropathy or dysesthesias, that's really the small fiber neuropathy. But if they have the numbness or the loss of protective sensation, they could have large fiber. And they can have a mixed picture. They could have pain but also numbness. It's possible to have both. But sometimes people don't have any pain, they just have numbness, and sometimes they just have pain and they have pretty good sensation, meaning they feel like they can step on something and notice it, but they end up having the loss of sensation as well, which is why it's important that we screen with the monofilament, the tuning fork, as well as testing for either pinprick or temperature. And so it goes into here kind of which fiber gets matched up with which test and why it's important that we're checking all of them. So early recognition obviously is critical. And then what's also astounding is that up to 50% of these neuropathy cases can be asymptomatic. So patients may have no symptoms at all. And that's why it's important that we screen at every year at the minimum. And like I mentioned before, glycemic control does not reverse the neuronal loss. So once they have neuropathy, they have neuropathy. And like I mentioned before, if you're ever questioning if it's actually neuropathy or something else, there is a whole slew of other things that can cause neuropathy. And sometimes it's a mixed picture and sometimes it's other things. But I'd say, for people that are primarily seeing patients with diabetes, it usually is neuropathy. However, we can get some other things that can complicate the picture. So I just want to review the monofilament exam really quickly because I feel like sometimes people think they know how to do it and it's done inappropriately. So essentially what you want to do is you never want to touch the monofilament wire itself. You always want to grab the handle or the paper or the plastic that's attached to the monofilament because your finger that touches the monofilament can actually change the exam. So you always want to touch away from the monofilament. And when you press on the certain areas, and down there in the red circles are the primary areas that are recommended for checking with the monofilament, although you can go through all 10. And if you have a little monofilament that we do, it actually demarcates which sites are important on the actual monofilament piece itself. And what you want to do is when you press on the site, you want to make sure that the monofilament wire bends at 50%. So you see a nice arc. If you're just lightly touching it, it's not bending at all, you're not really assessing the pressure needed. So when you're doing it, you really want to make sure that it bends, and then you let it rebound back, and then you let go. And you have the patient close their eyes, and you have, you go through the different sites. And I kind of move around from the left foot to the right foot because sometimes people kind of expect that you go and you know where they're going, and you kind of ask them to tell you which foot you're on just to kind of test them a little bit because, trust me, people do cheat. So in terms of treatment recommendations, and you can read the neuropathy position statement for this, it goes into way more detail on treatment. But basically and generally, obviously optimizing glucose control is important to prevent or delay the development of neuropathy. Assessing and treating patients to reduce pain to improve quality of life. And from there, pregabalin and duloxetine are really the first-line recommended drugs to treat neuropathic pain. So there are multiple other drugs that are listed that can help, but really these two are the initial recommended guidelines. And if you want to read the position statement, it goes into the treatment dosing and the other drugs and things like that, but those are the two that are really recommended. So I couldn't talk about neuropathy without mentioning Charcot. And I think that it's something that a lot of people don't realize is super important, especially in my field. And the way that this presents, it actually can present, and sometimes it's tricky because it looks a lot like cellulitis. So it actually presents as an acute edematous form, an erythematous, insensate foot. So in a diabetic patient that has all of these things, the first thing that you think of is it cellulitis? Is it infected? But this can actually look exactly like infection, and it's not infection. And so the key differences with how this presents is that inside what's happening is progressively the bones begin to break down. So this causes bony destruction, bony resorption, and then eventually progressive deformity and sometimes limb loss if the deformity is so great, or if the bone fragmentation is so great. Sometimes a ballooning amputation is needed. So this is just something that is very important to understand. So for type 1 diabetics, they typically present with this specific pathology in the 5th decade, and type 2 diabetes, it usually presents in the 6th decade. And in patients with diabetes, it is a relatively rare condition, about 0.1 to 1.4%. However, if they have neuropathy, it's about 7.5%. So it jumps up quite a bit. And so it's very, very important that we recognize this. 9 to 35% have bilateral presentations, and about 50% actually have pain. So even if they have neuropathy, this Charcot Neuroarthropathy can be painful. So it's just something to keep in mind. And there's different mechanisms of action. There's 2 different theories that are primarily discussed. The first is that it's neurotraumatic, so the patient is ambulating on an insensate foot, and the chronic trauma over time breaks the bones down and causes the fragmentation and the deformity. Or it's the neurotropic theory, so there's intrinsic issues with the bones itself that in an insensate foot predisposes them to break down. So again, either theory leads to the same endpoint. And the most important thing to understand is that an urgent referral to podiatry with offloading is critical. So making these patients on weight bearing essentially on this questionable limb. And when you get labs and you check x-rays, sometimes they're normal. So if they're normal and you're steering away from the infection diagnosis and you're in the back of your mind, you're wondering, could this be Charcot, then better safe than sorry and to keep them offloaded. So sorry, I apologize in advance for this overlap here. So essentially we have the 2 different staging systems, the Eichenholz classification, which is discussing the radiographic classification, and then we have the Brodsky classification, which is the anatomical classification. So the Eichenholz classification goes into stage 0 to 3. With the important thing understanding is that stage 0, there actually is no sign of Charcot on x-rays. And so you may get an x-ray and they could be completely normal and they could be in the beginning of Charcot. And the most common anatomical site for Charcot to present is at the tarsometatarsal joint. So where you see that rocker bottom deformity, that's the joint that gets affected most, and that's why we see the rocker bottom deformity, because it breaks down and then angulates. And then there are other joints that can be involved as well, so keeping that in mind. But what's really important to understand is that this stage 0 is the critical time when we need to really understand how to diagnose it, because there's been an article that shows that 67.6% of non-foot specialists really reported poor or complete lack of knowledge of Charcot. And so from there, they were missing the diagnosis and people were walking on it, and they missed up to 79% of the cases and averaged the delay of diagnosis up to 29 weeks. And so another article came out basically discussing that if you catch Charcot at stage 0 within a month of presentation, and you properly offload them, you refer them to podiatry, there was a low rate of complications. However, when diagnosed after 2 months, the sequelae formed, the bone started to fragment, and then the deformity presented and people were at risk for limb loss. So really important to understand that the diagnosis early is key. And then touching on PAD, so if anyone presents with any history of decreased walking speed, any of these things here, claudication, abnormalities in the pedal pulse exam, they really should be referred for an ABI or TBI. So what we recommend is that people always get a TBI with the ABI. So the toe brachial index is important because with diabetic patients, they get calcification of the artery, and so the ABI can sometimes be falsely elevated because the arteries are non-compressible. And so the digital arteries in the toes are less likely to be calcified, and so the toe brachial index is actually sometimes more accurate. So getting those, and they can do both at the same time. When they get the ABIs and the TBIs, it's actually quite helpful. And if there's any abnormality, then it should be referred to either vascular surgery or to a vascular specialist. And then we'll touch a little bit about Corn's calluses and pre-ulcerative calluses. So the calluses are not benign. So calluses form because of pressure, and in an insensate foot with neuropathy, these calluses can turn into pre-ulcer calluses, and then pre-ulcer calluses can obviously turn into ulcers. So important to understand that they do require regular debridement in our office, and it's important to reduce the pressure because when we even just debride an ulcer, it reduces pressure about 30%. And then when we actually implement offloading, shoe inserts, topical medications, things the patient does as outpatient, sometimes surgery, we can reduce the pressure even further. So sometimes surgery is needed to help internally offload, we say, removing sometimes arthritic conditions or things like that that can help improve the range of motion to prevent pressure buildup. Very important for that as well. Moving on to just, based on what I just discussed with the risk classification, we'll go into a little bit about when people should follow up. So this was also out of diabetes care, and they basically divided patients into 0, 1, 2, or 3 risk categories. And depending on how high risk the patient is, they should be seen more closely. So if there is no neuropathy on your exam, there is no evidence of PAD, there is really no deformity, the patient has good glycemic control, they really can be evaluated annually. And it's okay to be evaluated by the PCP, endocrinology, or even podiatry. However, if they have any of these other issues, such as neuropathy, deformity, if they have PAD, with or without neuropathy, it does increase their risk. So sometimes they have to be evaluated every 3 to 6 months just to be checked to make sure everything's okay. Not obviously they could be seen sooner if there's other things that pop up, but this is like the basic guideline. And then if they have PAD, it increases their risk, so every 2 to 3 months. And then if there's any history of ulcer or amputation, they really should be evaluated every 1 to 2 months. And sometimes if people show that they're doing quite well, sometimes it could be extended, but this is the basic general rule for what we use in the office to kind of keep people on track. And then this other article came out that obviously came up with an urgent priority. So instead of being a 0, 1, 2, 3, if they have an open wound, if there's any question of infection, if there's any signs of Charcot, things like that, they really should just be referred to immediately. And sometimes that means sent to the emergency room, but we're hopeful that if we catch things early, then they can be treated as outpatient as well. So that's the key with that is, people can be at the category 0, 1, 2, or 3, or they may need to be referred urgently. And now moving on to the last objective from today, we'll just go a little bit about the importance of diabetic shoes and inserts and the forms and the qualifications for that. So the key is that the people that sign the form for the diabetic shoes and inserts must be the physician that manages the patient's diabetes. So unfortunately, it can't be my specialty. It can't be from podiatry. It has to be from either endocrinology or the primary. And what ends up happening is that the paper that gets filled out that the patient then has to take to either orthotics and prosthetics or wherever they get their diabetic shoe gear and inserts, that form, if it has anything on that form, whatever it says on that form must be in the note as well. So it has to match. And sometimes what we do at our facility is we see the patient more frequently usually. So the other physician, the primary or the endocrinology, sometimes co-sign the note, just acknowledging that in our note we recognize the different conditions that the patient is deserving of these shoes and inserts and warrants them, and that they're really important. And so the key with understanding shoe gear and the inserts is that when they're measured for the shoe gear, they're measured appropriately for the depth, the width, the material, and sometimes they need to be custom. So sometimes there's a Charcot deformity, for instance, that sometimes it's fused in that position, and they need to have a custom shoe gear to accommodate for that. And same thing with the inserts as well. So if they have any specific complaint or any area of high pressure, like a callus underneath the first metatarsal, let's say, the orthotic can sometimes offload that specific site. So they are really important. And the key is that you get 1 pair of shoes with 3 pairs of inserts every year. So what's good is every 4 months, the patient can then evaluate the inserts, and if there's wear and tear, they can use a new pair. And they can actually take these inserts and use them in other shoe gear if they fit and they're appropriate. But the hope is that they use the diabetic shoes and the inserts really whenever ambulating. And this is all required by CMS guidelines, actually, too. So important to understand that there's 6 big qualifiers for which patients can actually qualify. So I think understanding these is really important, and we go through this all the time on a daily basis. So the first item that qualifies the patient is that they have any history of partial or complete amputation of any toe or foot. So that automatically qualifies them once they're healed they can then, or if they're already healed, then they can get a prescription for diabetic shoe gear and inserts, and then from there they can get fitted, and sometimes they need to have different accommodations, especially if they've had an amputation. The second thing is if they have history of a prior foot ulceration. So if they healed and they have, no other issue, even if it's a first-time event, they can qualify for diabetic shoes and inserts. The third thing is history of pre-ulcerative callus. So that's that callus with the sub-hemorrhagic keratosis that you see. Is there any bleeding in the callus? Or if when we tear the callus, it's noted that the skin is not 100%, but it's not fully ulcerated yet, but it looks like it is almost there. That also is a qualifying for these diabetic shoes and inserts because that insert can offload that specific callus area. From there, if they have neuropathy, they can't just get shoes if they have neuropathy. They have to have evidence of callus formation. So hopefully they meet one of these 6 criteria, and I'd say most of our patients do. But if they have neuropathy with evidence of callus formation, so when you document how you diagnose the neuropathy with the things that we talked about before, and you evaluate the sites of where the callus formation is, relatively specifically, then they can qualify, and then the inserts can offload the specific areas. And then in terms of foot deformity, so bunion, hammer toe, Taylor's bunion, which is by the 5th metatarsal, flat foot, high arch, Charcot, any of these things can help qualify as well. So you're probably going to find something for everybody, especially in one of them, unfortunately, in one of these 6 categories. And then last but not least, if they have poor circulation. So if they have peripheral arterial disease, if they have any history of prior surgery for vascular surgery, any weaker pulses less than 2+. So if they're not having normal pulses, if they're relatively weak, even a 1+ can qualify. And so if they have any abnormalities on the ABIs or abnormal capillary filling time, claudication, or cold feet, they also qualify. So something I'd say, unfortunately, for everybody, but we should keep that in mind, especially if they're going to be helpful to help prevent future ulceration. I think emphasizing their use is really important and getting fitted appropriately and measured. So with that, that's all I have. So if there's any questions, I think we're going to open it up for a Q&A.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your touch-tone telephone. Again, if you have a question, please press the number 1 key on your touch-tone telephone. Our first question will be coming from Gail Sullivan with Rockhaven. Please go ahead.
Hi, I wanted to know if I could get a copy of the sheets that you've displayed.
Sure. I think the slides should be uploaded, if I'm not mistaken, in the next week or so.
Okay. So could somebody qualify for orthotics or something like that if they have ulcers on their feet?
Yeah. So if they have active ulceration, I probably would recommend an offloading type of surgical shoe first to get it healed. Even sometimes a cam walker or a wound healing shoe, or sometimes there are other kind of specific offloading shoes first to get it healed. Sometimes people need total contact casting. So we do that a lot at our institution too for these plantar neuropathic diabetic foot ulcers. Total contact casting is the gold standard, but if it's something that you feel confident that you can use like a surgical shoe or something like that to offload, I probably would try that first. And then once that area is healed, or you feel like it's small enough that they can get fitted, then that would be an appropriate time to get them shoes and inserts. But again, swelling is a big factor, so you don't really want to get somebody measured for these devices with active swelling. So if there's any question about swelling or infection, I probably would wait until things calm down.
No, I understand. But could the orthotic prevent or help prevent future ulcers just by the way it's standing? It would correct it?
Yes. So whether the pressure point is coming from the foot type or if there's a specific pressure area, like if there's atrophy of the fat pad and the metatarsals are very prominent, there are different implementations for the orthotic that can be established, and they can help offload different areas and help reduce the pressure. And the orthotic itself does increase the proprioception and also equally kind of spreads around the pressure in the plantar fascia of the foot to help decrease the pressure.
Oh, okay, great. Thank you.
You're welcome.
Again, ladies and gentlemen, if you have a question, please press the number 1 key on your telephone keypad. Again, if you have a question at this time, please press the number 1 key on your telephone keypad. Okay, we do not have any more callers in queue for questions at this time.
Okay, we'll move on to the second part of the webinar. And if you do have any more questions, we'll open it up for Q&A again at the end, so you can ask them then.
Well, thank you. This is Barbara Link. I'm a clinical quality consultant with MPRO, which is part of the LSQIN. And I wanted to just give a brief overview today about the importance of vaccinations for people living with diabetes. So I just would like to recommend that the CDC has a wealth of information on their website specific to vaccinations and vaccinations for people living with different health conditions, one of them being diabetes. And if you're interested, you can just simply search CDC vaccinate diabetes or CDC vaccinate health conditions, and that'll get you right there to a wealth of information that I found to be very helpful. So why are vaccinations so important for people living with diabetes? Each year, thousands of adults in the U.S. get sick from various diseases, and that could be prevented from vaccines, and some people even are hospitalized and even die from these diseases. People with diabetes, both type 1 and type 2, are at higher risk for serious problems from certain vaccine-preventable diseases, and that's why it is so important for helping your patients understand the importance of getting vaccinated. For your patients with diabetes, please talk about getting their vaccinations and keeping them up to date. So even if diabetes is well managed within your patient population, it's still their immune system is compromised and at a higher risk of getting infections for this particular population. So they can be at more risk for serious complications from illness compared to people without diabetes. Some illnesses like influenza can raise blood glucose levels dangerously high. People with diabetes have a higher rate of hepatitis B than the rest of the general population, and people with diabetes are at an increased risk for death from such conditions as pneumonia, blood infections, and meningitis as well. So all of these support really talking to them about getting their vaccinations and keeping them up to date. So what are some of the most important ones recommended by the CDC for people living with diabetes? The typical ones that are important for all adults to keep up to date on, but for people with diabetes, the influenza vaccine, the pneumococcal vaccine, the Tdap vaccine, which helps to protect against tetanus, diphtheria, and whooping cough, hepatitis B vaccine, and the zoster vaccine, which protects against the shingles. So within the LSQIN, we have developed some toolkits and information to help support this, to educate your patients regarding the vaccines that they're needing. And we have a general patient information card that's very easy to read, and it's just a two-sided card with large print for people 60 and over that suggests all of the vaccines that I just talked about on the previous slide, which are supported for people living with diabetes, but they're also good for anybody the age 60 and over, and they're available through the Lake Superior Quality Innovation Network. So if you're interested, please go on our website and we can get you that information. Also, if there are insurance issues, if a patient's insurance doesn't cover a particular vaccine, many health departments provide vaccines at free or low cost for patients. So within the Michigan MPRO portion of the LSQIN, we've developed a site-specific sheet for the different health departments in the area and the clinics, their times that they're open, and so you can direct your patients to that. And I believe within Minnesota and Wisconsin, they'd be able to assist you with that information as well. So So I just wanted to give you a general overview today, again reiterating the importance of vaccines for people living with diabetes. I know sometimes people with different health conditions become concerned that maybe they shouldn't become vaccinated, and that is not the case with people living with diabetes. It's very important that they actually have all of the vaccines listed today, and that they keep up this on an ongoing basis, and that you please talk to your patients about the importance of getting vaccinated. Again, if you're interested in more information, you can always go to our website or the CDC's website, which has quite a bit of information regarding all types of vaccinations and different health conditions as well. Thanks.
And at this time, we'll open it up for Q&A. Today's slides will be available on our Lake Superior Quinn YouTube page within the next week. At this time, can we please pull up the evaluation questions? If you could take a moment to let us know how we did by filling these out, we would really appreciate it.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your telephone keypad. Again, if you have a question at this time, please press the number 1 key on your telephone keypad. Again, if you have a question at this time, please press the number 1 key on your telephone keypad. Okay, we have no callers in queue for questions at this time.
Okay, well, thank you everyone for attending the webinar today. We hope you learned some stuff, and thank you, Dr. Priesand, for presenting. And this concludes our webinar. Thank you.
Thank you, ladies and gentlemen, for joining today's webinar. You all may disconnect at this time, and have a good afternoon. Thank you.
Oh, that's true.